Welcome back from lunch, everyone. I'm going to turn it back over to Katie, who will help navigate us through the section set of federal groups.
Excellent. Thank you. Welcome back. I hope everyone had a good lunch. We will have the second session of federal agencies overviewing their agency's missions and how those relate to Parkinson's and related disorders. It will be the exact same questions, and then we will reserve questions for the end for a broader discussion. If you'd like to ask a question, please go ahead and raise your hand and I will try to call on you. Just a reminder that we'll try to call on people and not do council business in the chat, but if you put a question in the chat, I'll try to circle to you in the queue of people asking questions. You know, federal agencies, sort of as we've mentioned, might not be able to answer every question today, but we're recording them and we'll come back to you with answers as they're available. And with that, I think I will be turning it over to Rick Nichols, who will tell us about ACL.
Thank you, Katie. Again, it's a great honor for the Administration for Community Living to serve as a federal member of the council. Wonderful to be with you all today. Our agency is also known as ACL. It's my honor also today to represent Mary Lazare, who's our senior official that's serving as the Assistant Secretary for Aging and as administrator. ACL is one of many operating divisions within the U.S. Department of Health and Human Services. If this is the first time that you're hearing about ACL and the nationwide network of organizations that we fund, it's likely because you have not had a need just yet for long-term services and supports or some of the other needs that our agency addresses. Of note, nearly 7 out of 10 individuals in the United States that reach age 65 will have a need for long-term services and supports in their lifetime. And nearly 50% of these individuals will need paid care at some point. Relatedly, 20% of individuals who live to age 65 need an average of 5 years of long-term services or supports. A large portion of individuals with Parkinson's have a need for long-term services and supports due to the progressive nature of the condition, especially those with a tertiary level of care. Nearly 40% of people living with Parkinson's rely on unpaid informal caregiving. Many also relied on paid carers to provide services and supports in their homes. Separately, it's roughly 20 to 25% of individuals with Parkinson's who choose to transition into long-term care facilities like nursing homes or assisted living communities for assistance with their needs. So with all these trends in mind, if this is the first time you're learning about ACL, please listen up. While it's not too late to become familiar and drink deeply from the well of services and supports that are available through our networks that our agency funds, we absolutely recommend planning ahead for your needs and the needs of your loved ones rather than doing so in the moment of need. ACL's mission is to maximize the independence, well-being, and health of older adults, people with disabilities, and their families and caregivers. You can learn more about ACL's mission, our vision, and our priorities as it states here on the slide at acl.gov/aboutacl. Please also subscribe to the many announcements that we put out, including recently about a number of funding opportunities, 20 funding opportunities released last week, more being released this week and next. You can subscribe at acl.gov/subscribe. Let me quickly call out ACL's 6 priorities. You can read more on our website about what we're doing in caregiving, connecting people to services, whole person health at home, employment, preventing rights and preventing abuse, and economic security. ACL statutory functions with a budget of $2.7 billion annually. We administer more than 40 programs for older adults, people with disabilities, and family caregivers. Through these programs, we fund services and supports through a nationwide network of state, tribal, educational, and community-based organizations. We also fund applied research and a lot of innovation activities. All of these directly address the most pressing disability, health, functional, and rehabilitation needs faced by individuals with disabilities and older adults. ACL also has a really unique statutory role to advocate for people with disabilities and older adults. We do this across many areas of the federal executive branch by advising the HHS Secretary, all other agencies within the Department of Health and Human Services, and more than 20 other federal departments and agencies, all about aging and disability policies to address the needs of these populations. Next slide, please. Say that again.
About 1 minute remaining.
Got it. Let me quickly touch on home and community-based services programs. We serve more than 20 million individuals with disabilities and older adults every year. We fund organizations in every state, territory. We fund more than 300 tribes, 22,000 service providers. A lot of the services that individuals with Parkinson's might access are falls prevention, chronic disease self-management, nutrition interventions, transportation assistance, benefits and insurance counseling, and in-home personal care. As I mentioned before, a lot of individuals with Parkinson's, 40%, rely on unpaid caregiving. Our programs support more than 2 million caregivers annually. More than 60 million unpaid caregivers provide more than $1 trillion in unpaid care and support every year, and so it makes a huge difference. On average, caregivers of individuals with Parkinson's provide 31 hours of care. Let me call out on this last slide. You can access 2 nationwide tools that we have, the Elder Care Locator and the Disability Information and Access Locator, or DIAL. By using a zip code, city, county, or state, you can search for aging and disability organizations in your area. For organizations that are seeking to partner with the aging and disability organizations we fund, you can also locate them by using this tool. We hope this information is very helpful to you, your loved ones, those in your professional networks, and I and others at ACL look forward to engaging further. Thank you.
Excellent. Thank you. And we will move to Dr. Bellantoni from the, there we go, from the Indian Health Service.
Thank you, Katie. Good afternoon, everyone. I'm Maria Bellantoni. I am the Chief Clinical Consultant for Geriatrics and Palliative Care for the IHS, also a proud Commissioned Corps officer in the United States Public Health Service. And just a quick thank you, Rick. I know you mentioned many of the wonderful programming that your agency is doing, and we are certainly beneficiaries of that amongst many of our tribal communities. So we are well familiar with the ACL mission, and we're glad to partner with you in many of this work. Go ahead, next slide. So I'll quickly share the mission of our agency, which is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. Next slide. And a bit of information about our agency as a whole and how we serve and endeavor to fulfill that mission. So we are the federal agency designated to provide care for American Indians and Alaska Natives who are part of the 575 federally recognized tribes here in our country. And that amounts to about care for close to 3 million American Indian and Alaska Native people in our health system. We are quite a large system. We're, I think, tallied at the 17th largest in the United States currently. And we are also not a monolith of clinics. We are actually the amalgamation of multiple different types of service units, including our federally funded and managed IHS sites, tribal health services that we provide direct funding to, but are managed by the tribes themselves, as well as urban Indian health organizations, which serve Native populations that are currently living in more urban sites throughout the country. In total, that equals somewhere above 600 hospitals, clinics, and health stations nationwide, including Alaska. Next slide. just a brief overview of some of the programming and activities related to Parkinson's disease. So certainly as a healthcare provider, as an agency that provides direct care, we do directly oversee the provision of neurologic care services at many IHS sites. We are also very fortunate just because of the realities of some of the places where we practice and provide care that we have utilize some novel access strategies to make sure people get the care that they need when they need it. That includes things like using ancillary providers such as pharmacists, community health aid programs, or the CHAP program, which bore its roots in Alaska, as well as telemedicine services, which we have been using for almost decades now, perhaps earlier than many of our colleagues throughout the country. We also provide what's called purchase and referred care funding, which is money that we dole out to sites, to service units that can then purchase needed care services outside of the IHS. And those, again, would be often, in the case of Parkinson's, neurologic care when needed, if it cannot be provided directly by an IHS service unit. And then a little bit as well about the program that I'm directly involved with at the IHS headquarters, which is called the IHS Alzheimer's Program. And we are housed in the Division of Clinical and Community Services at IHS headquarters. Next slide. And I'll give you a little bit of information about that programming, because while it is called the IHS Alzheimer's Program and received funding for the first time in 2021 appropriations to care for those living with Alzheimer's and related dementias, our work is more broadly related to general elder care and geriatric services, as well as dementia and neurodegenerative diseases. That includes things like Parkinson's and related dementias. Our work spans sort of 4 priority areas. The first and foremost is grant funding that we dole out directly to tribes. And this is largely distributed as part of what's called an IHS Dementia Models of Care grants. We currently have 19 sites that we are funding to develop culturally relevant and locally powered programming to care for folks living with neurocognitive disorders, including Parkinson's, in their communities. I think we've all discussed some of the importance of an adequate and sufficient workforce to address some of these issues in folks already living with the diseases that we had mentioned. So we are really focused on building a capable and timely workforce to care for older adults, including those living with Parkinson's disease. And we have multiple programming nationwide in support of that. We also have funding to generally increase the awareness and outreach of folks who are living with diseases. We have many social media and other campaigns sort of aligned with HHS mission to make sure people are aware of these diseases. And then certainly we are really invested in making sure our programming is well supported in evidence and that we have the ability to collect data and to report back on the diseases we're seeing in our populations, but also how well our programming is able to address them. So I'll go ahead and stop there. Thanks so much for the opportunity to present about the IHS and looking forward to partnering with all of you.
Excellent. Thank you. We will move on to Captain Kumar, who will be talking about the Office of Minority Health.
Hello, everyone. It is an honor to be here in the presence of all of you today. I'm going to be providing a brief overview of OMH. HHS OMH is sharing a few key resources that we think will be beneficial to Parkinson's disease provider and support community. Our office sits in the Office of the Assistant Secretary for Health, or OASH, where the Office of the Surgeon General also sits, and which you already had the opportunity to hear from Dr. Herodopoulos earlier today. OMH is not a research-based office and does not currently conduct work specific to Parkinson's disease. However, we do acknowledge that disparities do exist in presentation, diagnosis, treatment, access to care, research participation among the Parkinson's disease community, and we will be working with the appropriate research and public health colleagues to better identify, understand, and address these disparities. Next slide, please. A little bit about OMH. Our overall vision is that all individuals, families, and communities are healthy and thriving. And we do this by providing national leadership, resources, and coordination to improve the health of and eliminate health disparities among racial and ethnic minority populations and American Indians and Alaska Natives. We also do this by working with diverse stakeholders, including federal government partners, healthcare systems, nonprofit agencies, communities, and the general public. Next slide, please. One of the first resources we wanted to share are the OMH Resource and Knowledge Centers. The purpose of these centers is to support better health information dissemination, provide health education, health promotion, and support disease prevention and service delivery. Our librarians and information specialists are available to provide technical assistance on exchange of such information. These two centers are similar yet distinct. The Resource Center provides customized information requests about minority health statistics, data and disparities, customized funding searches for your organization, speaker requests for HHS OMH leadership and staff to attend your organization's event, and general questions about the HHS OMH and the HHS OMH Resource Center. The Knowledge Center provides assistance in finding resources and literature related to any minority health topic of interest, as well as staff are available to provide responses to questions about accessing specific resources in the Knowledge Center online catalog. When you have the time, you can click on the link provided here, check out the online library catalog, type in Parkinson's disease in the search engine, which will then pull up a list of resources and articles specific to the intersection of Parkinson's disease in racial ethnic minority populations. However, due to the nature of how information is compiled and added to this catalog, available resources are not inclusive of all studies available. Next slide, please. And lastly, we wanted to share a little bit about the Think Cultural Health, or TCH, e-learning programs, which provide free online education or training focused on health promotion and disease prevention in culturally and linguistically appropriate ways. The ultimate purpose of TCH is to build the capacity of health professionals in addressing cultural and linguistic barriers to care, as well as improving the quality of and access to healthcare for individuals with limited English proficiency. TCH has about 9 targeted e-learning programs at the moment for a variety of health professionals, to include physicians, nurses, behavioral health providers, and more. And continuing education credits are also available through accredited organizations, and you can see a list of the organizations here on the slide. We have also included some data here on the reach and impact of our TCH e-learning programs. As you can see here, we have had about 1.3 million learners since 2004, and we've offered about 3.3 million total continuing education credits since then as well. And that is it for OMH. Thank you for the opportunity to share some information about my office.
Perfect. Thank you. We will go on to the VA, and I believe Dr. Lahozet will be presenting.
I am here. Can you hear me okay?
Yes.
Awesome. Thank you. Thank you for having me. I'm filling in for Dr. Duda today. He is out on vacation, so you guys are stuck with me. I'm the neurology chief in Richmond at the VA Medical Center, and I'm also the director of our Movement Disorder Center of Excellence here. Go ahead. So PD affects approximately 110,000 veterans nationwide. They are service connected for various exposures. So we have Agent Orange exposure with over 1 million veterans exposed. We have Camp Lejeune with the TCE and other pollutants. And moderate to severe traumatic brain injury during active service can also lead to Parkinson's disease as we age. And in order to provide this state-of-the-art care, including deep brain stimulation therapy, the Parkinson's Disease Research and Education Centers, which are called PADRECs, were established in 2001, and then they were put into code in 2006. Also in 2006, they developed a hub and spoke model and had associated sites, and there's 45 of those. And then most recently, we now have 16 regional Parkinson's and movement disorder centers. So trying to continue to expand our network from the 5 original sites to how much can we do across the country. Go ahead. So piecing it together. So like I said, in 2001, the 6 Parkinson's 5/6 Parkinson's research centers, the PADRECs, were created, and realized quickly that we really needed to expand the national network. We've been doing this through telehealth for many, many years as well, and it is now out to 60 VAs, and that includes those regional sites and the other associated sites. We now have the quality care indicators that we use from the American Academy of Neurology, and we've developed these to also give out and provide best care practices to general neurologists and other practitioners to explain best care, best practices in Parkinson's disease. Also used by some primary care, but mostly general neurologists. The research advances, so we do basic science, rehab medicine is huge, health services, clinical and translational research help really trying to improve the care of our veterans that have Parkinson's disease and other related movement disorders. Like I said, we've been doing telehealth for a long time as well. Before I started here, which was 13 years ago, they were already doing it. I think we've got better and better. Now we provide telehealth services to the entire country, including Puerto Rico. I have a couple patients there that I see virtually, which is pretty cool. So just reaching out and really providing that same level of care, hopefully, for a veteran who's here in Richmond as a veteran who is in Beckley, West Virginia, that does not have any neurologists around. Expanding awareness. So we have partnered with the PF, Parkinson's Foundation, which is the nation's largest, and it's international as well, Foundation for Parkinson's Disease, and really working to expand that awareness and the VA resources for veterans, and getting veterans to understand that we can provide this care so they don't have to only be in the community. We can certainly do this. We use a lot of whole health. We have multidisciplinary and interdisciplinary clinics and brain wellness clinics. Go ahead. So how do we do it? So we do face-to-face and telehealth. We will see patients completely by telehealth if we have to. Again, my patients in Puerto Rico have not been up here, and unfortunately, I haven't gone down to visit them there. So you just have to do it how you do it. Follow-up care, medication management. We do surgeries throughout the VA. Focused ultrasound is new, and hopefully will be coming to the VAs. That's only done in the medical centers right now. But we do deep brain stimulation on site at a couple of our centers. So that's the surgical care, mental health, psychiatry, and psychology. There is a national telemental health program specifically for Parkinson's disease. Social work, lots of it, case management, advocacy coordination to other VAs, community service providers. There is a PD caregivers program, which is huge, and it's throughout the country. We also do regional sites and do regional groups to try to cluster our resources together as best as possible. Rehab is fantastic in the VA, so we lean heavily on our colleagues with physical therapy, occupational therapy, speech pathology, vision rehab therapy, which is quite unique, music therapy. We're blessed to have recreation therapy and something unique called kinesiotherapy, which is functional movement. Also working with our palliative care colleagues when needed. Go ahead.
1 minute remaining.
Okay, so we graduated quite a few movement disorder fellows. We do a lot of teaching. Many stay in the VA. We have clinical rotations for thousands of med students and residents that come through. 125 nurse educators were trained, do lots of trainings. We have VA support groups, education programs, community outreach, and then that Parkinson's Foundation partnership in 2019. Go ahead. This is the last slide anyway. So the big study is a CSP study that is still continuing on, and that is looking at mental health and Parkinson's disease and some medication options. But as you can see, there have been lots of awards over the past several years, totaling anywhere from $4.5 to $8.5 million. So very active in research throughout all of the sites at the PADREX and the associated sites. So trying to really continue on that part of our mission as well. I think that's the last slide.
Perfect. Thank you.
Mm-hmm.
And we will wrap up with Dr. Ling, who will be talking about CMS.
Hi, good day. Can you just confirm that you can hear me?
Yep, loud and clear.
Okay, terrific. Thank you for the time today, and I am obligated to show you this disclaimer just to say that information and state of policy changes very quickly. So anything that I may reference today or have not said or talked about actually may be online. And please track day-to-day information that comes from CMS. Next slide, please. So with every administration, we have a refresh of the mission per our leadership's preferences and direction. And so the current mission is to ensure that all beneficiaries, even the most vulnerable, can and do receive high value care by leading all payers and supporting providers and clinicians. Next slide, please. And this is just a graphic depiction of all of the CMS statutorily supported and enabled programs and policy levers, if you will. I will just mention a couple of them over the next couple of slides or the next slide. And just to say, CMS's role over time has really been as a payer for healthcare services and for care across the care continuum. And over time, we have really emphasized the evolution from paying for services to paying for services that are of high value. That is, that achieves better and improved health outcomes for the people that we serve. And so that ties in to the mission of high value care. What is also depicted on this slide is the different receivers of CMS payment, not only providers, which we would consider all healthcare facilities that participate in Medicare, that is, are paid by Medicare, providing that they abide by and comply with the health and safety standards that are laid out in federal rulemaking, but also the clinicians and practices out there that CMS does not have oversight authority over, but does enhance the value of care provided by way of some of our quality improvement and quality measurement efforts. Next slide, please. So this is on the left side of the slide. Really, this is a illustration or an example of one of the important policy authorities that really is grounded in Medicare statute. That is coverage for treatments and services, and for any product, treatment, or service to be paid for, there must be coverage as well as coding, and then, of course, payment. The three go together, and these are just two examples. They're not the most recent examples, but illustrate the point that the agency has both national coverage determination authority that applies to all states, all territories, and also local coverage determinations that are established by the Medicare administrative contractors. The processes are similar, but the scope of coverage policy really is about 80% in the local coverage determination category. Both have the ability to cover as evidence accrues, as does Medicare by way of research supporting policies. CMS is not a payer for research, but does permit coverage and payment of reasonable and necessary treatments and services on the Medicare side, and also routine care and services as evidence accrues, and ideally wants evidence to be able to cover more broadly, dependent on the evidence and also that the treatment or service is reasonable and necessary. On the right-hand side of the slide is just an example of quality measures. Quality measures, the anatomy of a quality measure is that there's a numerator statement. Those patients or care recipients who actually have a condition or a outcome that is defined in the quality measure relative to the entire population that may be at risk or can benefit from a treatment or service or care process. And also on the left-hand side, illustrate how some of the measures are implemented. And here is depicted the merit incentive program, which actually supports quality measurement as well as through the reporting of these measures, but also by way of alternative payment models and alternative payments, really emphasizing the importance of coordination of care across time, space, specialty, and primary care. On the bottom of the slide are what we are, thank you, what we would consider improvement activities. That is, that a practice or a provider can illustrate that there's improvement underway that might not meet the criteria for quality measurement. Next slide, please. And I believe that was my last slide. So thank you for the opportunity and for the attention. Over.
Excellent. Thank you, Dr. Lang. We will open this up for our public members to ask questions. So just use that raise hand feature and then we'll call on you. Go ahead, Debbie. Debbie, you are muted.
This is directed to the VA. What lessons from the PADREX model could be applied more broadly to across the federal health programs and community settings, and perhaps share, if you can, your current connections to groups that may represent that but just aren't as apparent to us?
So I think we've learned a lot from being a small group of just those 5 or 6 when we started to really expanding out, really trying to understand how do we get these resources throughout the country. And I think that's been a challenge because there are not movement disorder specialists all around the country, or if they are, they're kind of hidden. So really trying to find and promote the areas that are the associated sites and the regional centers now, and providing education, really encouraging other centers to hire these specialists. And then when they can't, being there and being that backup and the education for the primary care, the docs, the nurse practitioners, and the general neurologists, if they're lucky to even have that, so that we can really expand that network out as much as possible. I think we try to do, just like everybody else here, as much as possible with as little as possible. We don't have a lot of funds. We try to share it all as best we can and really hit every veteran that has Parkinson's disease and be available at least for a resource and help managing all of that care. I think our partnerships with PF Foundation and really growing into our community networks. So we work very closely with our academic centers. We work very closely with our rehab facilities within the VA as well as externally to, again, provide that information and just be a resource to say we are here and we're happy to take care of you and do what we can.
Quick follow-up, do you have any, do research into or monitor opportunities in terms of specific areas around the country that have a concentration of members but no PADREC?
Yes. So we've been trying to expand we have 2 areas that really, Florida has a lot of veterans, actually falls under our Richmond catchment, but does not have a PADREC. Has movement disorder specialists in the area, like Dr. Kuhn here, so we're okay. But the Midwest also does not have a PADREC area. So Dr. Allison Willis, who's in Philadelphia, does a lot of demographic research and really those pockets and hotspots and try to figure out where those are and how can we best use our resources to help there. Some of those spots, though, have specialists at the big academic centers. So while we would love to get a PADREC and really VA facilities there, that might not necessarily be exactly where the biggest bang for the buck is, because there are people there that certainly can provide excellent quality care for Parkinson's patients. So that's kind of the figuring it out. But those 2 areas actually are the biggest that are not covered by the PADRECs. Having as close as somebody in Florida to Richmond is quite a distance to come and see us, or to go to Texas. So those are areas that we've looked at expanding and growing those.
Thank you.
Mm-hmm.
I see Dr. O'Kane, your hand is up.
Great, really terrific and great discussion. I wanted to
ask both on the Indian Services side and on the VA side, maybe lessons that you can just share very briefly with us, because it seems like the charge of this committee, and Debbie was just getting at this too, is there's a certain population of people that's growing with Parkinson's, and we kind of have to scale across the US. And now there are some success stories, and you may have success, maybe not even necessarily in Parkinson's, but in other programs that can be set up. And so how many centers of excellence, how many, practitioners, when you don't have practitioners in certain areas, how do you figure out how to scale that? How do we use geriatricians and start to think of things in a different way, so we don't keep trying to solve the problem in the same way that we've solved it before? And so I just was wondering if there are lessons learned from not only from Parkinson, but from other diseases in your areas that could really help this committee to figure out how to make recommendations to make sure that we are reaching everyone.
Certainly, and I can start us off, Katie, if that's okay.
Perfect. Thank you.
Yeah, I appreciate the question, and I think certainly much of our programming within the IHS has been more broadly based in other geriatric syndromes and dementia, but certainly includes Parkinson's related diseases. I would say there's been two big takeaways in our programming so far, which again is only about 5 years in its existence. But one is the importance of developing local expertise and championship when you don't necessarily have access to specialty care, such as a geriatrician. So one program I'll highlight is our IHS Geri Scholars Program, which is actually based off of the VA's program, similarly titled, where we empower clinicians that are practicing largely in primary care, where most of our constituents get the majority of their care, and giving them the skills necessary to be able to recognize, early signs of disease, such as Parkinson's or other dementias, and giving them the skills needed to be able to encompass most of the care that they need in the settings that already exist, like primary care. So it's sort of leaning less on highly specialized medical centers to really dole out, good care, which we know can be done in these settings. The second, I would say, from our agency is the incredible need and reliance on non-provider members of healthcare teams. So more broadly, clinicians. One of, I think, a real strength of our system is our community health aid and community health worker program, and how much sort of reliance we have on them, not only just to dole out sort of medical care in the homes and in communities, but also building trust with communities. So they're such a small percentage of time is spent in the exam room, as I like to say, and really using things like public health nursing, other ancillary providers, and community health workers to get folks the care they need, the education they need, and sort of the support, particularly for caregivers, I think has been a huge success across settings for us, and I think certainly would do well to be scaled kind of across other settings.
I'll echo that, and I will say the interdisciplinary team model is invaluable, and I think that's something that we've learned. And being in the VA system, we have a lot at our disposal, and leaning on our therapist colleagues and really asking people to practice at the top of their areas then allows the physicians and our specialists that really again are maxed out to focus just on really that patient care aspect. And I'm not worried too much about the gait and the falling issues. That is the specialized PT that is now working on that. So leaning heavily on that interdisciplinary care model and having that respect, not only within our VA, but also doing this remotely, instead of kind of having those collaborations and those care teams has been invaluable, because it allows us again to expand our resources out and use what we have.
Excellent. Thank you to you both. I do just want to pause and see if any of our other federal partners would like to chime in. And if not, we will go on to Dr. Whittingham. Oh yeah, go ahead, Sherry.
This is Sherry. Just to also say, one of the real strengths of VA that we have valued as federal partners is the evidence reviews that are done, and not in the Parkinson space, but in the pain management space. We recognize that the translation across across veterans that are also Medicare beneficiaries, over what I think it's like 50% now, maybe eligible. We've actually been able to utilize evidence gathered from the VA in expanding policy for coverage in pain management. Just to the point made, what can we learn from perhaps in other areas that could help facilitate translation of, into evidence-based care and evidence-based policymaking. So thank you. And thank you to my VA colleagues over.
Excellent, thank you. And I think this conversation will continue as we work on this plan. There's a lot of collaboration in this space already, and we're looking forward to using this as a platform to continue that. Dr. Whittingham, you have been patiently waiting.
Thank you. And I think Dr. Ling actually kind of got to what I was going to ask ahead of time. So this is for CMS. So similar idea, tag teaming off what Dr. Oken and Debbie had asked. A lot of the therapies that we are finding are helpful for people with Parkinson's, things such as rock study boxing and community exercise programs. The VA is set up in a way that they, can help, do some of these non-traditional therapies that maybe don't cost a lot of money, but our rural areas, our minority underserved areas that don't have all of the nonprofits doing all of these things aren't getting access. If there were a medication that worked as well as exercise, we would be paying a fortune for it, but there's not a good way to get somebody a personal trainer or to have Medicare pay for that. So is there a pathway to that could happen?
Yeah, so yes and no. The yes part of it is we have also learned the importance of being able to test out new care and payment models, right? Under Medicare and also under Medicaid. There's been a recent focus on care enabled by technology, as well as by expansion of the clinician types that are payable, perhaps incident to a physician service. So some of that important work happens in the CMMI, the Medicare and Medicaid Innovation Center, where their authority is to test new care and payment models. The requirement there is that at the end, that there would be demonstrated improvement in quality, lowering of cost, hopefully both, but at least either or, better quality or lower cost. The limitation is that how Medicare works is that the treatment or service has to fall under a existing benefit category. It is not one that CMS can establish without congressional approval. And so, we're kind of on the receiving end of it, so that it might explain some of the policies that you will see that, are enabled incident to the care of a physician, or because that physicians are a payable entity by Medicare by statute. So, but thank you for asking that question. It's really an important one. Over.
Thank you.
Perfect. Thank you. I see we have a lot of questions, so we'll keep going. But I imagine some of our colleagues from IHS or OMH might have some thoughts in that area as well. Jessica, go ahead.
Thank you. This is also a question for Dr. Ling. You mentioned the coverage for levodopa and for focused ultrasound for Parkinson's disease. Unfortunately, we know that those have limited benefit for the atypical Parkinsonian conditions, but a little bit more broadly than that, I was wondering if data are available or could become available in the formation of this plan on CMS coverage for other essential services that are used by all people with Parkinson's and the related diseases. So I'm thinking of things like rehabilitation therapies and modified barium swallow evaluations and Botox injections, palliative care, mobility devices.
Yeah, so what are available and accessible, and this is where, so there's a lag with the data sources that we have, especially those that are claims-based, and that is because it takes time for claims to be submitted, and if they are denied, then, a appeal or a resubmission. So anyway, there's a data lag, but those data can be accessed with specific codes that would be, so if there was a list of codes and procedures that are of interest to people with Parkinson's disease, Parkinsonism, it's a matter of what codes should be looked at. So we could certainly do some preliminary analyses, but just so that all know, people with a diagnosis of Parkinson's are kind of across the care continuum. Some of the information will not come from individual clinician claims, but may also come from post-acute care and rehab, skilled nursing facilities and the like. So what would be helpful is to know what questions would be top of mind to address by way of existing data and existing data sources. That would be an important first step, because there are so many different variations of a syndrome or a condition that may be coded differently. And remember, we have different coding systems. So we do have a team of experts that are responsible for managing the CMS data sources. So important step will be what codes, what details. That would be really helpful. Over.
Just to clarify, when you say codes, are you referring to ICD-10 codes?
Good question. We can look at any type of codes, whether they're ICD-10, there may be CPT codes, depending on what setting. There may be, so the actual diagnostic criteria that are being, applied. So to think about, what is a question you want answered? And then we can provide some clarification of where would you find, what kind of codes, because we have also learned over time that the world doesn't necessarily think in CMS terms about where the codes are, what the codes are. They're different because of the way that payment has been built over time by way of different and additional statutory authorities. So I don't want to lose sight of being able to capture the whole picture. So if you even lay out what the questions are and what settings, we can provide some guidance in terms of where to look for those codes. And often there are public use data sets already. Over.
Thank you. Dr. Boy, I see your hand is up. You are muted.
You would think by now we would know this. Thank you, Katie. I'm not sure if this is in scope or out of scope for this committee, but as someone who's been in the Alzheimer's Disease Research Center program for 20 plus years and seen the enormous benefits of how that has grown and provided not only research opportunities, educational opportunities, care opportunities, and the like, realizing also there's the PSP Centers of Excellence, Lewy Body Dementia Centers of Excellence, UDAL Centers, PODREX. Is a PD Research Center program somewhat similar to the ADRCs in scope or out of scope for this committee?
Does anyone want to take that one?
I'm sure the dollar signs are saying, oh, maybe not, but had to ask.
I think from a VA standpoint, that's in our PADREC mission. Research is in there. So like the GREC models, the other MIREC models, we have to have research incorporated in it. We are looking actually nationally and getting a national research coordinator to help expand out to those sites that don't have research coordinators. So there is actually one that is being hired right now to help expand it out nationally, but that is part of our core PADREC.
We might get back to you with some more information on that as we move forward.
Sounds good.
Debbie, I see your hand is up, but Israel had his hand up earlier, so I just want to check in with him and make sure that his question was answered.
It was answered. Thank you.
Awesome. All right, go ahead, Debbie.
This is for CMS also. Thinking about some of the advances in the Alzheimer's space and looking ahead, how are you thinking about risk assessment in Parkinson's and Parkinsonisms, early detection, and what future coverage can look like for biomarkers and diagnostic test access and improvements?
So I think that is a really important question that is being discussed, in the current sphere of the National Alzheimer's Plan. Really, it's the way, and this is both combining, my clinical role as a dementia care provider, but also what I know of HHS and CMS processes. It is really important to have clear focus on what are the outcomes that one would want to achieve and how would that be measured. We start with administratively defined outcomes such as hospital admissions or unscheduled care or readmissions, because they are administratively defined. They have a ready access, a ready data set that can be accessible. But, all in all, what that doesn't, it's not necessary but not sufficient when it comes to driving towards meaningful health outcomes for the people who we serve, whether they have Alzheimer's or other types of dementia or Parkinson's. So, what would meaningful health outcomes look like for the people who, we're serving here through this committee? And, once we have clarity on that, then we can also have further understanding of what is evolving in the biomarker space. And I'm using that term very loosely, whether it's imaging or a functional assessment or a blood-based test. Really, from the Medicare coverage standpoint, the treatment, service, or tests should be meaningfully used in the care and keeping of the individuals. That then will translate into better health outcomes. So just thinking about how important it is for us to get a clear handle on what the outcomes that would matter as we think about the different biomarkers and the role of the biomarkers is it's for, and it could be even a biomarker could be, symptom screening or a compilation of symptoms over time that might lead the way to detection of the condition, a diagnosis of the condition, and therefore also better management of the condition that then results in better health outcomes. But again, ending where I started, I think it is important for us to know what the health outcomes are that we should collectively focus on. Over.
Thanks, Dr. Ling. I will pause here and see if there are more questions. And if not, I think we have a few that were posed previously that we might want to circle back to.
Well, folks think I'll just say that we've got 5 minutes left.
Excellent, thank you. And Debbie, your hand is still up, so I didn't know if you wanted to
Yeah,
follow
well,
up.
I do. I have a follow-up. If I don't want to dominate, but if there's still time, I have a follow-up on CMS. So if I understand how you're describing this, there's kind of a system in place that is the existing go-to for kind of finding a structure for linking these the potential access to or coverage for a variety of actions like risk assessment or biomarkers, and it sounds like it's principally connected to improved care outcomes. I'm interested in, as when we think about not just where the field is today, but where it might go. You know, let's assume Parkinson's is not going to get reviewed again for 3 decades. So how do we think about where it can go? And so these are also key types of monitoring capabilities, and they're emerging and improving in drug development. And so how do you think about things like, for instance, if we know that particularly poor smell is measured by an upsit test, you know, what would keep us from seeing that get into, you know, the kind of Medicare general health assessment, so that we are starting to understand if someone is an at-risk person in PD, and kind of then putting them in a path for better monitoring, or saying, okay, so now we might pay for a biomarker test that's helping us understand if that person's biology is converting into symptoms, or et cetera.
Terrific question. So number one is having the evidence, and really also to be paid mindful attention to there may be outcomes that are disease specific, but when it also, you know, for us to push ourselves beyond a disease specific, this, that, or the other, to think about what would be clinically useful in the care and keeping of the person with the disease, who also may have other conditions going on. And, you know, we know from looking at the Medicare data that the heterogeneity is significant, and the complexity is increasingly significant, so much so that even in the Alzheimer's space, and we haven't looked at how this would play out for a diagnosis of Parkinson's, but we have for Alzheimer's. And approximately 4% or even less that of the original Medicare population have only Alzheimer's. They have a variety of other things, so that can interfere with the effectiveness of said therapy is. So to think about what does the whole person need in order to improve their health outcomes meaningfully. Just, Debbie, also to respond to your prior question, you know, about the system that is in place. So these are all statutory mechanisms to consider coverage, to consider payment. And, you know, the payment is in and of itself across different care settings, and they all run on their own train tracks. So just to say, for us to think about, if there is a new therapy, who can benefit, who can deliver, in what setting, and again, what are the, you know, the outcomes that really we're trying to all drive towards. I will say, in addition, preventive health benefits, I think you might have been talking about either the Welcome to Medicare, you know, which is IPPE, or the annual wellness visit. That is a statutory benefit, preventive health benefit. In order for that to, and there are other preventive health benefits that CMS has to consider covering in Medicare. The requirement is that the U.S. Preventive Services Task Force, that is under the Agency for Healthcare Research and Quality, they opine on the level of evidence that would support a screening test or preventive health service, and in doing so will refine their recommendations based on the evidence is A or B, which is what CMS has to pay attention to by statute. The committee will often refine the scope of the application to a subset in whom the evidence meets the criteria for A or B. And so, you know, if it's a C level, which is like indeterminate, or if there's a D level, it's, you know, a series of thoughts, as opposed to what the committee would consider, you know, sufficient evidence. Then I think, again, it depends on the evidence the evidence and the ability to actually look at that evidence and review that evidence for purposes, including Medicare coverage. I hope that answers your question. Yes, less than a minute. Sorry, over.
No, no worries. Dr. Ling, I think you're going to be very popular as people start to try to understand how care is covered for Parkinson's disease and related disorders. I think we will wrap there. I will just point out that a lot of the questions were about data and how people can use that data to answer the questions. So clearly sort of a bit of a thing to think about as we move forward. And I'm going to turn it over to Dr. Bonnie Adams, who is going to talk about how we're going to move forward.
Thank you so much, Katie. And thank you to everybody. I thought all of the presentations were incredibly thoughtful and crisp. And I really appreciate the engagement around the discussions. I'm just really excited about the work of this committee, and it's great to be able to roll up our sleeves and dig in a little bit. So I'm going to take just a few minutes at the beginning of this section to talk a little bit about some lessons learned from how the NAPA process sort of unfolded, and to think a little bit based on some of those thoughts about how we might want to move forward here, and then have a really wide open discussion to really dig in a little bit to this group. How are you thinking about approaching our charge to develop recommendations around how to advance Parkinson's research, care, and services? So I'm looking forward to it. So can we have the next slide, please? So just a reminder for those of you who haven't been following the Alzheimer's space as closely, in 2011, the National Alzheimer's Project Act was signed into law. And there are many similarities between it and the National Plan to End Parkinson's Act that I believe were intentional on the part of the crafters of the Parkinson's bill, because there are many ways that NAPA has been really helpful in still stimulating and galvanizing progress in the Alzheimer's space. So, in the NAPA Act, as in the Parkinson's Act, both call for the creation and maintenance of an integrated national plan to coordinate research and services across federal agencies. Although the federal agencies are ever so slightly different, there's a lot of overlap. To accelerate the development of treatments that would prevent, halt, or reverse the disease, to improve early diagnosis and coordination of care and treatment of the disease, to improve outcomes for populations at higher risk, to coordinate with international bodies, and also to create an advisory council to review and comment on the national plan and its implementation. And so that's called the NAPA Council in the Alzheimer's space. There is a key point of distinction, though, that I just want to clarify. So the National Parkinson's Act calls for NIH, following input from the Advisory Council, to develop an estimate both of the current federal costs to around research, diagnosis, treatment, and care and services for people with Parkinson's, and an estimate for what it would cost to accomplish the national plan. That request was not in NAPA. Instead, what happened is there was a separate piece of legislation, the 2014 Alzheimer's Accountability Act, which was specifically focused on NIH to develop a professional judgment budget focused on activities related to NAPA, but within the NIH mission space. And that process has driven a tremendous wave of investment from Congress into Alzheimer's research, but it really has been focused only in the research space under the, mostly focused in under the NIH umbrella. So I just wanted to sort of clarify that up front so that that distinction was clear. Next slide, please. As they have moved forward to implement NAPA, the most recent plan has 6 goals with related strategies and action steps. So those goals are very broad. And one of the reasons that we are surfacing this is as an example for you guys to think about and react to. We don't need any kind of final decisions now, but to begin to think about whether this is the level of specificity in the goals that makes sense to you. To prevent and effectively treat Alzheimer's disease by 2025. That date had its pros and its cons, which we'll get to in a little bit. Optimize care quality and efficiency, expand supports for people with Alzheimer's disease and their families, to enhance public awareness and engagement around Alzheimer's, to track progress and drive improvement, and to accelerate action to promote healthy aging and reduce risk factors. So that goal came on in later iterations of the plan. And, we've already begun to talk a little bit about the role of prevention. And so risk reduction has the potential to be part of that. So just something to think about. Federal actions were informed by this, which by the recommendations from the council, by public comment, by issues that emerged in the field as a result of some of the conversations that happened through NAPA. And also through various topics that were raised by the federal partners. I'm just pausing for a moment because I don't see the slides anymore. Is that just me?
No, Amy, that could be us. There might be an IT. I think they're coming back.
Okay. Perfect. Thanks. Next slide, please. Oh, actually, I'm so sorry. Can you go back one more? I just want to note on the right, it talks about the fact that the national plan covers Alzheimer's disease and also the related dementias, which includes Lewy body dementias. So under the Lewy body dementias umbrella includes Parkinson's disease dementia. So that is a complicated area for us to consider as we move forward, just because it is therefore an area that is explicitly included both in the Parkinson's Plan Act and in the Alzheimer's Plan Act. And so there was a question earlier that perhaps we can get to in the discussion part about how to have these two councils think carefully about how to align with each other, to learn from each other, but not to duplicate effort. And so I think that that area in particular is going to be an important one for us to watch. Next slide, please. So some of the lessons learned from NAPA, this input I want to really appreciate the Assistant Secretary for Planning and Evaluation, ASPE, who helped to manage who are the individuals who manage the NAPA process. They helped us think through some of the lessons that they have learned from managing NAPA for almost 15 years now. It really is helpful to have a clear and patient-centered approach and mission. A strong partnership between the public members and the federal council members is really critical to having a really robust set of recommendations move forward. And so I think we're off to a great start. I think that will be further deepened when we are able to have our first in-person meeting later in November. To have extensive and inclusive collaboration with all partners. And one of the things we would love input on as we move forward is how to have a very inclusive approach to engaging additional stakeholders. To be not broad in everything though, but to have more of a targeted search for opportunities and gaps so that you can have some specific goals or targets that are achievable and where you can declare victory. Use every tool available to you, both in the public and private sector. Set goals that are flexible enough to adjust to new work and initiatives. The opportunity to have this annual plan allows us to really highlight many accomplishments both in the scientific space, but also to recognize new cross-cutting initiatives and advances in care and service delivery. And also that having a subcommittee structure allowed for deeper work to happen. And so you'll hear a little bit more about that in the next presentation by Dr. Sarah Dodson. Next slide, please. There are some challenges that they have experienced in managing NAPA over the years that I just wanted to surface for folks to think a little bit about. It is hard to balance the timeline. You don't want the timeline to be so slow that it sort of languishes, but doing things in an extremely compressed and crunched manner can limit the completeness, thoughtfulness, and impact of the national plan. So we are hoping, as I said at the outset, to deliver our first national plan as soon as possible. But we want to make sure that that plan is excellent. I know we're all aligned in that. So we're going to have to balance really hard, fast work with a reasonable timeline. A lot of the real impact comes in partnerships between the federal government and states and the private sector. The federal government and the private nonprofits and individuals and others represented on this council cannot do it alone. But operationally, it's really difficult to engage with and reflect all of the state, local, and private efforts and to navigate the opportunities there and to make sure we are maximally leveraging them. So I would welcome thoughts as we move forward about how to do that more effectively. We need in finalizing our report to balance being comprehensive with being accessible to all of our stakeholders that are interested in the report. So, for example, the GAO was charged with recently reviewing NAPA efforts, and they were wondering, for example, if there might be a every other year cycle where they have a sort of more of a high-level overview versus a more complete documentation of every effort going on in this space. Something to consider. And finally, to balance ambitious goals with pragmatic action. So, for example, NAPA came out strong with a goal of preventing or developing treatments for Alzheimer's by 2025. There are approved treatments that hit the market before 2025 that have the ability to modify the disease progression. But I think for many people, they were hoping to have something closer to a cure. So you know, it's really a balance between wanting to be bold and audacious in setting our goals for this group and making sure that we don't overpromise and also that we are able to tie those goals to really pragmatic steps. Next slide. So these are just a few examples of high impact actions that emerged from NAPA. There was a fantastic awareness campaign on alzheimers.gov that was kicked off early on that has had a number of not just impacts, but it has gone through a number of different iterations, including more recently thinking through how to partner with some of the agencies to extend their efforts. So that's something to consider, whether that could be part particularly of some sort of prevention effort as well, if and when appropriate targets are identified. One of the things that NAPA does is it sets up research summits that happen on a rotating basis. One is focused on Alzheimer's disease. The next year is focused on Alzheimer's disease-related dementia. And then the third year it is set up focused on care and services. Through our partnership with the National Academies for the next few years, we will have in every year both a research and a care and services summit. So we might just think over time how that works and if we want to continue with that approach over time or adjust as we move forward. It's worth keeping in mind you can add or remove goals. So for example, as I mentioned, the risk reduction goal was added recently in response to input from the committee. The guide model, which is which hopefully we can hear more about over time, but it's an integrated care model, was developed in large part through a number of the conversations that happened through NAPA and has been presented in that setting multiple times. The ACL work on living alone with dementia has also emerged through a lot of conversations that happened throughout NAPA. At every NAPA meeting, somebody from the Down syndrome community would come and provide a public comment to highlight the disproportionate impact of Alzheimer's disease on the Down syndrome community. And that had a real impact in highlighting awareness across all of the federal agencies and scientific communities. So all of those are just things to keep in mind in terms of potential impact. Next slide. So with that background, I wanted you guys to just reflect that what we're doing is not unprecedented. There is a precedent. We don't have to follow that precedent exactly, but it's always good to learn from those opportunities. And it would be good for us to think through, how do we want to approach our really important work? So we're hoping over the next 30 minutes or so to have a discussion about how you want to approach the goals and principles, so that as we are setting up sort of organizationally how we do it, we have heard from you and we are sure to align to your input. And we also want to make sure moving forward that in addition to the incredibly rich array of voices that are represented on this committee, that we are thinking about how to broaden that funnel even more and get input and guidance from an even broader set of the community. Because it was very difficult for us to narrow down the incredible nominees to just the extraordinary members of our council. And certainly there are many, many important voices that we weren't able to directly engage through the work of this committee. So I just want to note we have this request for information, which was published today. Thank you to the team that we hope everyone will help us promote. We will have 2 public workshops, which will have public comment periods in addition to each of our advisory committee meetings. And also through the work of our subcommittees or working groups, there will also be opportunities to engage with other voices and perspectives. So I just wanted to put that out there. Next slide. So this is my final slide, and I'll just leave this up here to help us guide the next period of conversation. But I want to hear from you guys. What are you thinking as you approach the work of this committee? What goals do you have for this work? What are the principles that you think should guide our work? And maybe we can start there and then move through some of the other questions on this slide. Dr. Boag?
Thanks, Dr. Adams. This is great. Again, as I chatted in the chat section, I've been involved with the NAPA plan for several years. I just found the experience enormously rewarding to see how comprehensive the vetting process, how involved all stakeholders are in each setting, and the staggered approach. So, for example, if I don't know if this is open for discussion, but one focus on PD, another session focused on PD, RD, another one on care and services. That model has worked really well in the AD sphere, and it's gotten really complicated now. You know, bringing in TDP 43 and head trauma in multi-pathology dementia. So I just think the model is a great one. whether it's followed exactly or closely, I guess that's obviously up for debate.
Thank you so much. And just to build a little bit on information that Jordan shared earlier in the day, we are working closely with ASPE to have sort of coordination in the back end in terms of support for NAPA and for the Parkinson's Council. We are doing everything we can to ensure sort of alignment, both of process and content where appropriate, while giving the two councils the leeway to do their unique and specific work. But we appreciate that endorsement, and any other specifics that you appreciate or would rather avoid, please just let us know as you think of them. Dr. Stander?
Yeah, Amy, thank you. That was great. And, you know, there's a lot to do here. And I guess I'm thinking about where to put our energy. I guess I'm struck by the fact that our charge, the act is the National Act to End Parkinson's. And if we're truly after ending Parkinson's, then we're really after how you can understand the cause, how you can reduce the risk from environmental aspects, how you can treat it early to prevent it from becoming a significant condition. And so, you know, there's a whole sort of space of energy into ending Parkinson's. On the other hand, you know, there's a need to provide care to the people who have it. So how much energy do we put into better use of existing treatments, creating access for the therapies that we have that are difficult for people to access? A good example is deep brain stimulation. I mean, I think everyone agrees that the utilization of that is much lower than, you know, would be optimal for what's out there today. So I think we're going to have to decide how much energy is the emphasis on ending Parkinson's, and is that really the only end game here, or is there a broader charge here of improving access to existing therapies and improving the outcomes of people affected by Parkinson's today?
The full text of the act does really lay out a very broad charge, which includes not just developing treatments and cures for the disease itself, but to enhance access to care and services. But to your point, which is well taken, as we move forward through the charge, we can't do all things to all people all the time. So it will be important for this group to prioritize some of their work early, understanding that that eventually we're going to have to get to making thoughtful recommendations across a wide spectrum of activities. Jessica?
Well, first of all, I just appreciate that point, because that's something that's, you know, I think top of mind for all of us, is striking that balance between supporting quality of life and quality of care of people living with this now, but while also identifying steps to move the needle with research through, you know, prevention and biomarkers and effective treatment. So I'm glad that that's something that we're all thinking about. But thinking about principles, you know, something that always strikes me with Parkinson's, and I'm hearing it in this conversation too, is that I think we need to recognize the incredible heterogeneity of Parkinson's. You know, Parkinson's alone has incredible heterogeneity, you know, in terms of how it progresses and symptom management needs and lived experiences. But how do we, I'm going to keep saying this, but like strike that balance between coming up with a plan and laying out recommendations that address commonalities across the whole Parkinsonian community. So things like how this is, you know, it's a very movement disorders centric field that we operate in. Well, we also know that we need to better consider the behavioral and cognitive and other non-motor symptoms of this, and end of life experiences and access to care, but then also laying out recommendations in this plan that address some of the unique distinctions and needs across special groups, like people with young onset Parkinson's, or, you know, gender specific, or veterans. And then, you know, I'm always going to come back to the atypical Parkinsonian disorders as well, because a lot of what we're talking about as far as the access to care needs, the biomarkers, clinical trials in development, there's a disproportionate burden of a lot of this upon the people with PSP, CBD, and MSA because of records lost, because of incredible delays to diagnosis in the context of worsened prognosis. So just something that, wondering how we're going to keep coming back to that of what will be helpful for the community at large, while also what will be helpful for specific subsets of this community that we're trying to serve.
Yeah, thank you. That's a great framing, I think, of the challenge before us. And I think it's something, we'll wrestle with together in these initial conversations. I'll just echo what was mentioned earlier about the NAPA process, where they sort of rotate sort of the areas of focus from meeting to meeting. So that just might be something to consider. You could imagine focusing on common common symptoms, common causes, and then more unique or specialized needs. I'm not sure. I'm just throwing things out there, but I think we have a few different ways that we might approach this. Debbie Brooks?
Yeah, when I think about the principles, I think that the two things for me that I can't escape is that we really need to think about how to scale our recommendations that meets both the opportunity that exists in science today, but also the burden that the government already carries, and that trade-off. And there's a lot of upside there. Things that have been done in the past or in small bits and pieces, just without the scaled support of those, they can't have the impact that that we're seeking, I think, for any part of our population. So I think for me, that's something I want to keep pressing on. And the second is that when I think about the scientific opportunity, to me, the biggest thing I see today is that we're on the cusp of, in part, able to, and I believe in the coming years this will improve dramatically, to be able to shift our mindset from a series of symptoms that send people to a series of doctors, some in common, sometimes not. This heterogeneity, or the way we think of it today, is poised to shift to really understanding more where the biology of disease is coming from, and the biology overlaps in individuals as they're aging, and it shows up in a whole group of different conditions. And so, to me, biology-driven considerations can't be lost in the shuffle of our current construct of thinking of things as symptoms and diseases that were diagnosed before we had tools and the capability of being more nuanced. And so and those things, by the way, go together. You need scale to accomplish that. And I guess I'll just make one point on something David said. This concept, it's very hard to think about how do you phrase what our intentions are in a way that is broad, because there's so many stakeholders and constituents in different parts of this equation around such a complex and demanding set of diseases. But even the debate between treatments versus cures, for me, the one that I zero in on the most is just if we can continue to make investments and that help us better address the progression of disease. And that could be progression as disease is advancing in people who are diagnosed. It could be prevent ever going from having a positive biology to a set of symptoms at all. Prevent by eliminating known causes of the the disease, you never progress to getting the biology. And so to me, I'll lend that as just a construct that to me, it has the chance of being broadest. But to your point, Amy, I think that we don't have to be worried too much. The bill, to me, it does have some broadness to it, but I think it'll be hard to think about how to organize our recommendations and our priorities as we think about these challenges.
Absolutely. I think you captured it well. And I love thinking about it as finding a way to intervene at any point in disease progression. I think that does cover quite a lot, both in the research and in the care and services space. Michael Oken.
Hi, thanks. Some great comments, and following on everybody's comments before, I just want to say, I think that to David's comment, the ending that's in the name, Parkinson isn't one disease, and we have other diseases that are part of this act and this bill. And I think fundamentally we need to think about this in the context of getting something done. And I think, there's a lot of people watching us, and there's been a lot of promises made for a lot of years, about curing this, curing that across a lot of diseases. And so I think part of the ending is a bit of a construct that you have to think about from person to person, disease to disease, and also prevention on the one side and therapeutics on the other side. And the second point is that we must get something done. So I look at these lists that are really broad that come out for both Alzheimer's, for Parkinson, for the overlap with Lewy body, and I say, oh yeah, great. These are very aspirational, but I think we're going to need specificity of what we think we can do over some shorter time interval that's going to then longitudinally change the field, rather than focusing on, like hand waving that, oh, we're going to do this. I think we need to, as a group, start to think about some specificity about what we can do. My last point is on making our mutual fund blended and balanced. And so I think we have to think of prevention and all quarters of that. So primary, secondary, tertiary. Okay. So and that gets at what Debbie says, so we don't forget about symptoms and symptomatic and changes, and also biomarkers, and what David said, the learning why does it start? Why does it progress? Why is it, why does it, and where does it start, right? So all of those W's are really important, and there has to be an investment there. If we don't understand where it comes, we don't look upstream, we're going to be in trouble. And so certainly we have to pay attention there. The care models and care plans are just not adequate. Michael J. Fox led a great initiative with lots of foundations and partners to show $82 billion, right, and direct and indirect costs. And Carly Tanner and I were recently at a PD Global Summit, and we both agree that that's underestimated for a number of reasons, conservatively estimated, but underestimated. And so we're talking about a lot of impact that can happen with changing those care systems and models, moving our chess pieces differently, thinking about primary care, thinking about how we fund people like we fund cardiologists and nephrologists, things like that. And then the navigation to new therapies, as David, mentioned, and Alice mentioned too, and thinking about, not only the biomarker side, but thinking about how those investments will go, so that when we get to a certain amount of time, we don't just say, oh, we made a list of very ambitious, audacious goals. We actually pushed, the field forward. And so I just am going to vote for more specificity as we begin talking and pushing ourselves to be more specific. But yeah, great discussion.
Yeah, thank you so much. And just to further expand a little bit on the NAPA model, again, not because I am pushing this, but just as something to react to. The goals that they set are very broad, but when they drill down to the level of, for example, the research summit, it is there that they come out with very specific goals and milestones to sort of push progress in very specific ways and areas. So So thinking about that kind of multi-pronged approach where the overarching goals are large and flexible and can be sort of evergreen and adapt to where the science takes us, but also having an arm of this that provides that specificity to drive action, right, is something they need to consider. Jessie Pedman.
Yes, thank you. A lot of those comments I echo as well. A lot of what they said is what I wanted to mention as well. One thing that I will say is we do need to be intentional about the translational aspect of this. You know, there's a lot of things that we learn in research, and it can be very slow to adopt in the clinic. And so just thinking about ways that we can, once we learn something and we know it to be true and there's evidence for it in research, that we really focus on that adoption in the clinic, the education, and so that it's not so slow. You know, one of the reasons why we're talking so much about biomarkers is it's really frustrating to people in the Parkinson's community when it takes so long to be diagnosed, and there's a lot of misdiagnosis and things like that. So I think just being able to translate that from research into the clinic is something that we need to be watchful for.
Absolutely. I really appreciate that point. And the other thing that I want to surface from our own translational research group, who did a series of roundtables a few years ago, one of the things that emerged from that in terms of moving things through the translational space is to think about identifying, making sure we have a broad suite of targets to potentially be pursuing, and not to overly focus on one. I think that is the lesson that the Alzheimer's field has learned, and they now have diversified their target pool. I think Parkinson's has a number of targets. I don't mean to suggest it doesn't, but just to think about how to emphasize that, because it's hard to know what will work through the translational pipeline most quickly, and again, also what might work in different people, right? As we talked about different people experiencing the disease differently, and or having it in the context of other biological events. So thank you so much for that comment. Alice Jen Plotkin, please.
Yeah, I just wanted to kind of say certain things really resonated that different other people said, and then I wanted to say one other thing. So the first thing, I really loved what Debbie said about kind of targeting progression in all forms, because this is a little bit what I was talking about. Parkinson's can be slow, and it can be sort of mild. And so being able to target progression, it is in essence, I always say it's winning the game, right? So I think kind of that really resonated with me. Another thing that kind of really resonated is what Jessie said about being intentional about translation. And I think that means kind of figuring out how to accelerate trials too, right? Because because you have to go through the trials to get into the clinic. And I think, taking some of the things we talked about at the translational workshop, which, I co-chaired with Bill Martin, there were good ideas there that we can kind of borrow. The last thing I would like to say is that while I am, Michael, I'm with you. I'm a get things done kind of person. We've got to remember we are the inaugural council here. And as the inaugural council, if you are not ambitious enough, it's only going to become less ambitious or more measured over time, And so I think kind of we're in a really beautiful place biologically. We know so many leads kind of from genetics and from biomarkers, many, many targets. Increasingly, those leads are being worked out mechanistically. When I think about like what we didn't know when I started in Parkinson's disease, I think kind of it is not unreasonable to think we will have basically disease modifying therapies in the nearer term. And I think we should be ambitious. That's the point I wanted to make there.
Thank you so much. I really appreciate that. Israel Robledo.
Yes. I want to, Debbie, as usual, right, spot on. Oaken, very good. Plotkin, very good. One of the things that when I get asked about a cure for Parkinson's, I kind of liken it to a cure for polio. If you think about it, if we can stop it from ever starting, we've done well. I mean, with polio, with the vaccine. So let's say you have polio, let's say you have Parkinson's. What can we do to slow down the process so that it doesn't incapacitate you? If you're advanced stages of Parkinson's, how can we provide the care and the services that will make you comfortable, keep you safe in your environment, et cetera? So we're in a good spot, honestly, from my perspective, is we can actually say, what I would feel comfortable is to say, this is what we're working at. We want it to stop before it even starts. And this is how we're going to show it, et cetera. So, Buck, and you're spot on as well. We have a lot that we can cover that is usable, that will give people hope while we continue working for that total cure. Hope it makes sense in some way.
Absolutely. Thank you very much. I think that's an important point. Michael?
Yeah, I just want to respond and just say, Alice, I agree with you. And you and I both know both of us are quite ambitious and quite, try to take on probably too much and say yes to everything. And so I do think we should be ambitious with this first plan. However, it needs to be a plan, we really, if we go into this and we're so broad and so ambitious, there's a real risk we won't get anything done. And so I think part of the charge of the committee is to make sure we set the infrastructure, lay that foundation for that house as well as we can, so that we can keep moving forward, because this is going to be longitudinal. And like, for example, we all talk about prevention. We spend 2 to 3 cents on prevention across the world, not just the United States. Best places are 4 cents out of every dollar, right? That it's going to take longitudinal monitoring, right? It's going to take us understanding how to count cases. So there's a lot of things that have to be put in place to begin to look at these things. And then to Debbie's point, and I also like her point about looking at across the disease progression, we're going to have to measure these things, and then as we measure, we can create impact. So I think my caution is that we get so ambitious that we lose a bit of the opportunity to really put those foundations and to decide what those foundations are going to be. We shouldn't lose our ambition on targets and therapies and all of those things. I'm all for it. I just want to make sure that that we're thinking in terms of a constructed, well-constructed, well-balanced plan as we move.
About 3 minutes remaining.
Thank you so much. Kathy, comment?
Yes, thank you so much for all these comments. I did want to weigh in on the importance of increasing access to care, particularly as our demographic is increasing. I mean, I mentioned that I've been providing care for a long time, and I have never seen at such a level of new diagnoses and all of the changes in science. And I can only imagine that the visit with the movement disorder specialist is going to get longer and longer as we look at precision medicine and all of this. So I'm really hopeful that although the science and certainly finding a cure, we really have to be able to provide care for people. Otherwise, there will be a problem for sure.
Absolutely. And another piece of that, which might be out of scope at some level from the work of our council, is encouraging the training of more neurologists and movement disorder specialists, right? Because otherwise, it's not just that the visits with them will get longer and longer, but the wait to see them is going to get longer and longer in a way, and it's already too long. So thinking about how to balance needs there too, I think they're important point to consider. And I think Michael brought up some of these points earlier. So I just wanted to note that. David Standard?
I was just going to say, I hope it's not out of our scope to focus on expanding the workforce here, right? I mean, it's a critical need.
Yeah, no, that's fair. That's fair.
The medical workforce, the scientific workforce, we really need that on every front here. And people solve these problems, and we need the right people and the best minds working on
Yep.
this, and that has to be part of what we're doing, or I don't think we could succeed.
Yeah, I think that's a fair point. I was just trying to think about what that kind of recommendation would look like, trying to be more specific. But nonetheless, good fodder for future discussion, because I completely agree with you that research doesn't do itself, right? And care isn't provided out of the air, right? They both require people, and I absolutely agree with you. So I appreciate that. So in the last minute, I just wanted to surface the question about what additional information or analyses the council might need beyond the inventory of federal programs that we have been working on and pulling together for you. So, I think we probably have to pause and move on to the next agenda item, but I leave that as a question for all of you to think a little bit about. And if you want to either put it in the chat or email it in to Jordan, for example, we can be working on thinking through how to provide you all with the information that you think would be most helpful. This won't be your only opportunity to ask for additional information, but we wanted to ask for it early. So with that, thank you all. This was an incredibly thoughtful discussion. And I am now going to turn it over to Dr. Sarah Dodson to talk a little bit about how we are going to set up a work plan moving forward.
Thanks so much, Amy. Hi, everyone. I'm Sarah Dodson. I'm a senior advisor at NINDS. I'd like to take just a minute to share my personal connection with Parkinson's disease. My grandmother, when I was in high school, she was diagnosed with Alzheimer's, but pretty quickly developed severe motor symptoms, complicated cognitive symptoms that weren't necessarily consistent with a pure Alzheimer's diagnosis. And, seeing her go through that experience, seeing my mother providing care for her, really was a formative experience for me, and motivated me to pursue a doctoral degree in neuroscience and conduct research in dementia and the Parkinson's space. So I couldn't be in a better space right now than to be working with you all in this council and helping to support the council, because it's just incredibly important to myself and everyone on this call, I know. So what I'm going to do is get into the nuts and bolts, really present a proposed work plan, see how you all feel about it, and then we can really start to organize and structure our work and get the council moving. So next slide. So this is pretty busy. Let me take some time to walk through it. But this shows a timeline, really walking through calendar year 2026 and 2027. We've plotted out when we expect to hold the full council meetings, several public input opportunities, and the formal reports that are required under the statute. So just to start with these full council meetings, you'll see the key is located on the bottom half of the slide. The full council meetings are shown in blue dots with an orange dot in between. There are 8 council meetings plotted here between now and the end of 2027, with these first 4 taking place at an accelerated pace so we can really get off to a good start. Next, I'm going to just walk through quickly the public input opportunities. So those are shown here in orange, starting with the request for information, which was just opened, and again will remain open until August 22nd for anyone to share your thoughts on what you believe should be in the national plan. Each full council meeting has our public comment time. We've already noted over 160 public comments have come in prior to this meeting, so the engagement with the community is already really high, and we're very pleased about that. There are also the 2 workshops that we've talked about, and we're proposing to hold those in the spring to summer 2027 timeframe. Following the workshops, that would give the council the opportunity to take that input and to develop their report, your report, with your recommendations and your priority actions. Again, here we're hoping that that could be accomplished around the summer to fall 2027 timeline. And then allowing us to take a couple months after your report for the federal government to develop the national plan and publish that before the year, before calendar year 2027 is up. So that's the general structure, general idea for the timing and how to move the council along. Next slide. So talk a little bit about process. We suggest beginning with 2 subcommittees, one focused on research and regulatory programs, and one focused on care services and supports. The council may decide to restructure these subcommittees in the future, add groups in the future. We do think sort of starting simple and starting with these 2 might be the best way just to get off the ground for the time being. Both of these subcommittees can be charged with probably the highest priority activities are those that are required under law, hosting the respective workshops, and really developing your recommendations and priority actions for the council's report to the secretary. Additional activities within these subcommittees can include things like just developing overarching goals for the council, identifying topics and speakers for council meetings, developing stakeholder engagement strategies. As Amy mentioned, identifying topics for independent analysis projects, because we do have the ability to perhaps do some side research for this group, and then providing progress reports during the full council meetings. Next slide. For subcommittee structure, we're thinking that each subcommittee can have 2 co-chairs, one public member co-chair and one federal or proxy co-chair. These meetings may be closed to the public, but any findings and recommendations must be presented at open council meetings for full deliberation. I would like the subcommittees to meet at least once between the full council meetings. It's important to note that additional non-voting experts can be included in these meetings as consultants, and NIDS will provide the scheduling and note-taking support. So we'd like to really just ask every council member to select which of these subcommittees you would like to serve on. If you feel like you have the bandwidth to serve on both subcommittees, then you're welcome to do so. We may need to Jordan may need to take the DFO's prerogative to assign or rebalance if needed. But again, if the committee likes this approach, we would like to move quickly to get this all settled. And so the action item or the timeline is here at the bottom of the slide. But by July 8th, which I believe is next Wednesday, it'd be great if you could indicate your subcommittee preference and if you would be open to serving as a co-chair. The following week, we can schedule a meeting for the council chair and or DFO, meaning Amy and Jordan, to meet with the co-chairs and strategize on goals and process. And then hopefully before August 14th or so, the subcommittees can have their first meetings, which gives us about 10 days before the August 24th council meeting. So I will stop there and open the floor for your reactions and discussion. And you can, I think you can unshow the slides unless there are any questions, but we can look at the gallery view. Yeah. All right. Alice Chinplakin, please start us off.
Well, I just had one question. So first of all, I think I should be on the research side, just to kind of balance things. So I'm happy to do whatever you want me to do. But I thought that one of the things we're also supposed to do is recommend sort of an estimate of what this will cost. Is that not true? And if so, shouldn't that be one of the things that's, we should actually gather information on and try to do?
Yes, and it's an interesting piece of the legislation that it does ask if Jordan would like to speak on this. The legislation sort of directs Secretary and the federal government to develop the estimate. I think we are very much hoping that the council will help in that respect.
Yeah.
So I think that it is a major part of the overall National Parkinson's Project, and we absolutely will be engaging with you all on that. But Jordan may want to say more.
That is exactly right. I think that could look like a lot of different things. It could come in the recommendations, and again, it kind of depends on how we structure the recommendations. If they're structured around research and care and services, or if we find a way to, after the groups have figured that out, integrate them. But as you think about that, if there are data sets you need to help you make that estimate, that is something that would be good to know as early as possible, because sometimes getting that information can be challenging.
I think we're helped by the fact that there has been a NAPA before, and we should know basically what the NAPA investment has been over the years. And I do think that kind of we can make all the plans and all the dreams in the world, but if we're not funded to do these things, it's difficult to get done. So I think this is a very critical thing for us to definitely do.
I will point out NAPA's bypass budget legislation specifically looked at research funding, not care and services. And there's nothing that prevents us. And in fact, we're instructed to look at care and services in terms of the estimate. So there will be some other data that would be required to help maybe flesh out that side of it.
That's a good point, Jordan. Hey, David Standard.
Well, I was just going to put in a vote to say I think your plan sounds pretty reasonable. I mean, we have two fundamental arms here. We're holding two workshops. It seems like two subcommittees would be where we would start. So, and there's not that many of us. We don't want to split into too many subcommittees. So I would think as a beginning point, I would endorse your strategy.
Thanks, David. Sarah Whittingham.
Hi. Yeah, no, I agree with Dr. Standard, but I also want to make the point too that I think it's important not to break down silos as much as we can too. I would like not to have all the researchers on the research committee. It would be good to have a researcher perspective on the care and services committee and vice versa. I think it's really important that there's a person with Parkinson's on the research committee, even though we may not know all the, the latest, what's going on in the research world. But I think it's important to have a variety of both perspectives on each committee as much as we can. As we build it.
Excellent point.
So if I can build on that, in addition to the subcommittees, it's true that everything will eventually need to come up to this committee to talk about. That doesn't prohibit like interim check-ins from occurring. So there can be cross discussion, and then things can break out or expertise can be added.
I believe Michael Okun is next.
Hi, thanks. I think these comments are great. Love your comments, Alice and Sarah and everybody who's spoken already, and David. I would just say that because you have a limited number of people on this committee to start with, at least the small group of us that were appointed, aside from all the agencies, it might be useful to just have, core members of the committee. I think you kind of were getting at this on your slide, but allow everybody to attend both committees if they can, but have core members of the committee so that we can make sure that everybody is represented. And for example, Alice, you're obviously great in research, but I've also talked to you before. You've got some things to say about being a movement disorders neurologist, and also, I think a lot of our organizations that are represented, I think that the folks that are coming in from gerontology and other specialties in neuropsychiatry, I think the voices are so critical here that even if you have the committee functioning, because smaller committees actually get more done, right? But if you have the committee function where you can have some non-voting members and both sides can kind of attend on, I think that could be a way to mitigate this. And maybe to Alice's comment, maybe part of each committee gets charged with it's like the congressional budget office, like a little bit about what the cost, what and also opportunities for leveraging, opportunities for showing, like how, like we can be working together and building bridges to try to get the amount of resources increased across multiple areas. So anyway, agree with all.
Excellent. Thanks, Michael. Debbie Brooks.
I would like to participate in both committees, and obviously sometimes challenges can get in the way in terms of calendaring. But one of the things I like about the committee structure is that we can bring in other experts, and that provides extra leverage. So we aren't really just 10 people or whatever, 23 people trying to convince each other or something. We can get more data, more input. And I believe that those also ease the burden on the government side. You guys don't even have to be part of those meetings, which means they can be, we can do a lot of ideation and generation of input to shape the framework that we want to hang our recommendations on. And so it does help extend the expertise beyond this group, which I think will be meaningful. But the subcommittees, I'm right, that we can invite other people to participate in the subcommittees. Yeah.
Yes, let me clarify a little bit there. So, for each of the subcommittees, it is required that, for example, the designated federal official, Jordan, will be at all of those meetings. I will likely be at all those meetings, and we do have, our federal members. A federal member will serve as a co-chair for the meetings. So there should be, robust representation from both the public members and the federal members on those committees. For individuals or additional experts, you can include them in meetings and in those conversations that take place. They can provide their thoughts and their advice to the subcommittees. They themselves are not considered members of the subcommittee, and they can't vote and those kinds of things. It's really that's reserved for the council members. But yes, that's where we also believe it's the best. Gives us the flexibility to get additional input as the subcommittees do their work.
As Sarah mentioned, we anticipate public and federal co-chair. The flexibility is that the federal members are often able to delineate an alternative. So that should help with either making sure the right subject matter expertise is in the room, or that we can get the calendars to work out, because we're asking for an ambitious timeline.
Thanks. Jesse Kibney.
Thanks. Yes, I'm also interested in being in both subcommittees, both as a research participant for the research side, but also from the care partner side on the care and services. One question I had was, I was curious about a little bit more about the format of the public workshops that are scheduled tentatively for next year, what that entails.
Sure, I can speak on that for a minute or two. I think the format is we're as Dr. Adams mentioned and Jordan too, we're engaging the National Academies of Science, Engineering, and Medicine. So NASM is going to help run those meetings and plan those workshops. The timeline to start that process is still a little up in the air, but the plan is that once we have an agreement with the National Academies set up, that they will meet with the council and we'll have an initial brainstorming session on how both of those workshops should look, how they can. I think it would be really important to talk about the how they can coordinate across the workshops and have some crossover content, as well as the individuals who are really thinking through the agendas on both sides, because we do not want to silo these two very critical pieces. So I think there's a lot to be, sort of the clay has yet to be molded for those workshops, because we were really waiting for you all to jump on board and to get this Academy's contract. So I think that's at least a beginning to how those workshops can take place. Brad Bouvet. Brad, I think you're still muted.
I think after 5 years, we have this down right. Just for more clarification, we have great PD expertise represented with this committee. Do we have enough PDRD with this committee? In other words, if we have ad hoc people, that's going to get a little complicated, but how do we do this quickly and efficiently? So enough MSA, enough CBD, enough PSP, enough LBD, so forth.
Well, one thing I'll say is with our federal partners, we have collected several names of experts that from the federal side that we know that we've worked with, researchers in that space as well. I think maybe we even have, I don't know, I don't want to promise, over 50, over 100 names, potential people that we could engage. But I agree with you that getting the committees, getting the council's ideas on who those sort of best people are, and to as quickly as you all can get them, and we can collate them, and we work together to determine a good set of those additional experts to add to both of the subcommittees. So I think that's a good goal for us to have, that before our August 24th meeting, that we have those individuals identified.
Thanks.
David Standard?
Well, I was just going to make the point. You do have 3 movement disorder neurologists on here, and PD-related disorders is an integral. You can't practice in Parkinson's without seeing patients with PD-related disorders, right? It's a movement disorders practice. It's not a Parkinson's practice. None of us can do that. So I think you have some experience here. Now, it's true that there are people who are deeply interested in one or another of these with great knowledge, and we might want to bring one or another of them in. But the thing about the Parkinson-related disorders is they are often not diagnosed as a distinct disease for quite a long time, and are certainly present in every movement disorders clinical population that all of us see and care for.
Yes, excellent point. Debbie Brooks.
I think I remember during our orientation, we talked about subcommittees, but we also talked about the working groups. And I think that these are some of the, we have 2 tools at our disposal. And I'm not sure we've really talked about working groups today, or maybe I'm off my agenda pace, but because that's a place where we really can go and might be particularly leveraged, where around needs, I can see them both scientifically, but also in the care area. The needs might be quite different condition to condition, and so this the working groups can also be an asset. I think the hardest thing is we do still have quite an aggressive timeline, and so figuring out why we would need a certain point of view, getting those people convened, and then figuring out how to really take advantage of their inputs is a tall order perhaps, but the working groups, I think, give us additional flexibility.
It's a good point, Debbie, and we've received advice from our federal committee advisory experts that working groups. One way we can use working groups is if there's a time limited and very specific challenge or task or issue that we want to have a sort of spin off a group to really look and dig into that one. But as you mentioned, with our short timing, we think probably most efficient at this point just to get the subcommittees started, really focused on the workshops, the recommendations, and the other issues that you all sort of elevate to the priority in your subcommittee deliberations. All right. Yes, go ahead.
I was also I'll finish up by saying, and I'm interested in participating in both subcommittees. I'm willing and happy to serve as a co-chair on the research one if that's helpful.
Excellent. Thank you, Debbie. And then Israel.
I just want to comment that a lot of what we're going to see is those public comments. Haven't read all 162.
Wow.
There is hurt in our communities. They need help. And it's evident in every single one that you read, the passion that they have. We need help, and we need to provide that help.
Couldn't agree more. The urgency it's right there. And we will hear some public comments really just in a few minutes around 3:15. We'll have several of those individuals be able to offer their verbal remarks, which are incredibly important to frame the work of this council. Michael Okun?
I just want to amplify what Israel just said. And that is, and a lot of comments out in the community in a lot of ways, and a lot of people really invested already in this process, really want to see it succeed. But, this is real. This is real for these people. And we need to be extraordinarily sensitive, open, transparent, ambitious, but also realistic, and continue to have them as partners along the process. And having Sarah, Israel, and others on this committee is absolutely essential to our task and what we need to do. But I mean, this is what it's all about. And so I really do want to amplify what Israel just said. I mean, we are here because we want to impact these folks. So super important.
Absolutely. I don't see any other questions, but I'd like to ask if Amy and Jordan would like to comment a little bit on our process and your thoughts right now.
I'll just add that in addition to adding permanent members to a subcommittee or a working group, you can also invite people to come and speak, which you might decide is the way to get the input you need to help develop the recommendations. This is an annual process multiple times. I channel one of my mentors who says, do not let perfect be the enemy of the good. And so perhaps we can do as much as we can with this year, knowing that next year we'll even make it better. And I will turn it over to Amy for some concluding remarks before we go to the break.
Thank you so much. I think I agree with everything Jordan just said, and also encourage you to think about the workshop planning. Your advice and guidance on the topics in the workshop and potential areas of focus will be incredibly important in the planning of those workshops. And some of that could complement, right, some of the work and expertise that you have available to you easily in the working group / subcommittees. I think as we move forward, I'm delighted to hear there is so much interest in serving on all of the subcommittees. I have to say the enthusiasm of the members is very much like the enthusiasm of the people submitting the incredible amount of public comment we got. And I think this just goes back to the point about there being a real sense of urgency to move this forward quickly. I think we will ask, though, each of you to pick one of the two subcommittees to be your primary subcommittee just for scheduling purposes. It is not trivial.
Recording stopped. Recording in progress.
Undertaking to schedule these meetings given the pace before us. And so I think we would do that, but I absolutely agree with the suggestion to keep them open to all members. And so I think with that, I will stop being between you and a well-deserved break, and we can move on to a 15-minute break, and we'll ask that people reconvene at 3:15.
Produced by the U.S. Department of Health and Human Services.